We are going to talk about the diagnosis, the differential diagnosis, and the management of ventriculomegaly. And we will start by defining what is ventriculomegaly. We have to remember that the lateral ventricle atrium must be evaluated in the screening scan at any gestational age. To perform its measurement, we should make a transthalamic plane with the lateral ventricles and the reference points, which will be cavum septum pellucidum and the two thalami, being aware of having the two hemispheres in a symmetric way. Once having this transthalamic plane, we should perform the measurement at this level, perpendicular to the axis of the ventricle and at the edge of the choroid plexus. Nevertheless, depending on the gestational age, this choroid plexus can be more anterior, so we're going to do the measurement at the parieto-occipital fissure. It is important to place the calipers in the internal part of the lateral ventricle. The normal values are below 10 mm throughout the gestation, and any value above 10 mm will be defined as ventriculomegaly. As you can see in this slide, the proximal ventricle is difficult to assess, but at least we should try to identify it and see if it is symmetric with the other lateral ventricle, because we could have a pathology of the proximal hemisphere, and if not evaluated, it could be left unnoticed. And what is important to remember regarding ventriculomegaly? It is important to remember that it's not a diagnosis, but a sign, which means it is saying that something is wrong, and so it is the most sensible marker of central nervous system anomaly development. Truly, the ventriculomegaly can be a consequence of different central nervous system anomalies, so it means it's non-specific, which means that when we see it, we know that something is happening, but we don't know what it is. And also, it is evolutional, which means that maybe at 20-week scan we didn't notice it, but it evolved, and we detect it in third trimester. For example, generally we could find a ventriculomegaly in 1 or 2 of every 1,000 pregnancies. And what should we do when facing a ventriculomegaly? We should carry out a study in which we are going to find out which is the cause of the ventriculomegaly. In 60% of cases, the underlying cause will be malformative, which means there is an anomaly in the development of the central nervous system that is causing the ventriculomegaly. For example, neural tube defects, midline defects, or posterior fossa anomalies. In 10 to 15% of cases will be secondary to an acquired pathology, which means something that happened in the gestation, as could be an infection, hemorrhage, or a hypoxic ischemic lesion. And finally, in 20 to 30% of cases, we won't be able to identify the underlying cause, and then we will classify it as isolated ventriculomegaly. And how can we differentiate the different causes of ventriculomegaly? Performing a complementary study and performing a detailed anatomical study. The ultrasound evaluation will help us to identify the cause, and the complementary studies will help us to confirm the pathology. Let's just start with the ultrasound evaluation. The first thing we have to do is to perform the measurement of the atrium, and thanks to the measurement we can diagnose that ventriculomegaly but also classify it in severity grades. Mild, between 10 and 12 mm, moderate, between 12 and 15, and finally severe, all of those of more than 15 mm, or hydrocephaly depending on the author. So, once we see the measurement, we are going to focus in other things that will help us to suspect a pathology. One of them is the morphology of the lateral ventricles. In this video, we can see how the lateral ventricles are disposed in parallel, and we are unable to detect a cavum septum pellucidum. This image is of high suspicion of corpus callosum agenesis, just seeing the absence of cavum septum pellucidum and the morphology of the lateral ventricles, we can think in a pathology. The next thing will be to assess the periventricular area, which should be homogeneous without cyst or echogenicity. And despite that in this video we can see these echogenic structures, it's not smooth, and even destruction cyst. When seeing this, we have to think in a hypoxic ischemic cause or an infection cause. Other thing that should be evaluated is the intraventricular area, the content of the ventricles. As we can see in this video, we can find these hyperrefringent walls. And also we see this heterogeneous image, which is a clot. This is highly suspicious of intraventricular hemorrhage. We also have to see if the dilated ventricles are just the lateral ones, or if there is a dilation of the rest. As you can see in this video, there is a massive dilation of the lateral ventricles and the third ventricles, but without seeing dilation of the fourth ventricle. This probably will be a secondary to stenosis of Sylvian aqueduct, so the assessment of the ventricles will allow us to determine the location of the obstruction in the case there is one. Other things are the parenchyma that could make us think that there is a tumor, for example, as this case. We also have to assess the subarachnoid space, which could be increased, as this case, with a reduced cerebral parenchyma. This must make us think that there is a reduction of the cerebral parenchyma due to a hypoxic ischemic event. The third thing will be to assess the posterior fossa. The ventriculomegaly associated to banana sign or lemon sign with collapsed posterior fossa will make us think in a neural tube defect. The ventricles are not just dilated but have this particular form, straight, with sharpening form. This must make us think in a neural tube defect. And finally, we have to assess the biometries. It will be a case of a fetus with measurements below from what it is normal for its gestational age. Also, it has a cortical hypodevelopment from what is expected for the gestational age. When we see these findings, we have to think in a lissencephaly as a probable cause. Once we assess the measurement and the characteristics, the morphology, the periventricular area, the intraventricular area, the third and fourth ventricle, the parenchyma, posterior fossa, we have a suspicion diagnosis. But beside all these, we have to describe whether it is uni- or bilateral ventriculomegaly, if it affects one or both ventricles, or also if there is a ventricular asymmetry, which is defined as a difference of more than 2.5 millimeters between both ventricles. With all this, we have a suspicion diagnosis. We have an idea of what is happening, but we need to complete the study to confirm the diagnosis. Let's see which are the complementary studies. The first thing, we have to perform a complete anatomical study, because in 40% of cases, there will be an associated anomaly, from which 50% of the extracranial anomalies will be congenital heart disease. And we also have to take into account that the associated anomalies are even higher, 60% if there is a karyotype anomaly. Maybe the most useful information is that when the ventriculomegaly is inferior to 12 millimeters, the percentage of associated anomalies will be under 10%. Nevertheless, if the atrium is more than 12 millimeters, the risk of associated anomalies will be multiplied by 5. Therefore, we should never ignore the anatomical study in the mild cases, but in moderate and severe cases, we will need to be more aware of the situation. The recommendation will be to perform a screening ultrasound and an echocardiography in all cases to rule out the presence of associated anomalies. Regarding the chromosomal anomalies, the rate of associated anomalies is between 3 and 10% of cases, and as you can see, is more frequent in those cases in which there is an structural associated anomaly, multiplying by 4 the risk in comparison with the isolated cases. We should know that the most frequent anomaly is the 21 trisomy, but it is not only one, and in fact, since the array is being used, the rates of chromosomal associated anomalies have increased, being of 3.6% in isolated ventriculomegalies and of 11.4% in those cases of associated anomalies. Therefore, in all cases, being them mild, moderate, severe, or even isolated, we should offer a karyotype study, and the parents are the ones to decide whether they want to do it or not, but we should always offer it. What do we do regarding infections? In 10% of cases of ventriculomegaly, and the rates are superior in the cases in which there is a severe ventriculomegaly, as we can see here in the charts. The most frequent ones are the cytomegalovirus, toxoplasma, and rubella. And in the majority of progressed cases, we will find other ultrasound markers, as we can see here on the slide. But we have to know that maybe the ventriculomegaly is the first sign we find when facing an infection. Due to this, in all cases we will ask for maternal serologies, and in those cases in which there are signs of seroconversion, we will offer the possibility of performing an invasive test so the assessment of the infection in amniotic fluid can be done. Finally, the MRI will help us to evaluate the cortex, especially in advanced gestational age, as we can see here in the actual section, and the comparison between the ultrasound and the MRI. The question will be, does it give us additional information? Generally, it can give us additional information between 6 and 10% of cases, but in mild and apparently isolated cases will give us information just in 1% of cases. What we do know is that MRI will help us if there is a suspicion of a cortical anomaly, as it can be a delayed maturity or suspicion of polymicrogyria, or indirect signs of pathology at this level. So, we won't indicate an MRI in all cases of ventriculomegaly, and we will reserve the evaluation in cases where there is severity criteria or progression, and when facing high suspicion of cortical anomaly. And when are we going to ask for it? If we want to assess the cortical development, we will ask for it at 30-32 weeks. As a summary, we have to say that when we find a ventriculomegaly, we have to perform a morphological study, including an echocardiography and infection serologies, and act in consequence. We will always offer the analysis of karyotype, and finally, we will reserve the MRI for those severe or progressive cases and those cases with high suspicion of cortical anomaly. Also, we have to take into account that when diagnosing a ventriculomegaly as isolated, in 13% of cases we will be wrong. And in reality, it will be a ventriculomegaly with a malformative or acquired pathology, but that we were unable to identify. And we should also share with the parents with this information, that there is this rate of false negatives, and that we will try to reduce the false negatives with the complementary studies that we will perform throughout the gestation. Regarding the prognosis, we have to know that the most important factor will be the size of the lateral ventricles at the moment of the diagnosis. As you can see here, the presence of associated anomalies in the mild ventriculomegaly is very different from those moderate or severe ventriculomegalies. Also, the impaired neurological development will be different in those mild cases and in those moderate cases, in which the rates reach 25%. And also the perinatal and neonatal mortality, which is of 3% in mild ventriculomegaly and reaches 10% on moderate ventriculomegalies. Therefore, the size will be the most important factor to take into account when advising the prognosis. But there are other factors. The second important prognosis factor will be the progression. We know that when a ventriculomegaly is progressive, we'll have a poorer prognosis regarding chromosomopathy, which will be multiplied by 20, the rate of impaired neurological development, which will be multiplied by 4, the rate of associated anomalies, and finally, the adverse perinatal outcome is multiplied by 16. So, if we see a ventriculomegaly that has increased in the follow-ups, we should change the prognosis and adapt it to the progression we are seeing. It is also important to remember that there is no association regarding gender, laterality, or gestational age at the moment of diagnosis. And how many ventriculomegalies will progress? In mild ventriculomegaly, only 10% of them will progress, but in moderate cases, the progression will be seen in 30% of cases. We consider progression when there is an increase of more than 2 mm between one evaluation and the other. And is there any other factor that could help us? A few years ago, we tried to identify whether the assessment of the anterior horn was a prognosis factor regarding ventriculomegaly. We evaluated if the anterior horns of more than 3.5 mm had a predicted capacity of the cases that will have poor prognosis. And the study showed that in those cases in which there was a dilated anterior horn, which was more frequent among moderate cases, had 30% of adverse perinatal outcomes in comparison with the non-dilated anterior horns, in which the adverse perinatal outcome was found in 5% of cases. And when evaluated the capacity of association towards outcomes, we found that both dilated of anterior horns and gestational age at the moment of diagnosis constituted poor prognosis factors, independently from the size at diagnosis. So when we see a dilated anterior horn, we evaluate most exhaustive these cases, because we found that these cases were associated later to cortical abnormalities. So we don't take it into account by giving a poor prognosis, but to evaluate exhaustively the case and assessing the cortical development. So, in the cases of mild ventriculomegaly, and especially those that are stable, the prognosis will be favorable until 90% of cases. And in those moderate ventriculomegaly, the prognosis will be favorable in 75 to 80% of cases. This is the information that has to be transmitted to the parents. And which will be the follow-up? The follow-up will be done every 2 weeks with two objectives. One, to evaluate the size and assess whether it is progressive or not. And two, to try to reduce the rate of false negative. Because every time we see the ventriculomegaly, we will not only measure it, we will also reassess the intracranial structures and see if there is something else that claims our attention, which wasn't identified before, because we couldn't or because it didn't appear at the time, because were progressive anomalies that appear later on in gestation. If it is stable, we can delay the follow-up to every 4 weeks. And if it progresses, we will follow up it every 2 weeks. And as I said, detect new anomalies and evaluate the progression. What about the severe ventriculomegaly? We have to know that they represent a third part of cases of ventriculomegaly and is diagnosed when having an atrium of more than 15 mm. In cases of severe ventriculomegaly, the necessity of surgical derivation is high, until 75%, and globally, the neurodevelopment impairment is around 70%. We know that in cases of non-isolated ventriculomegaly, stillbirth is present in 3% of cases, and neonatal mortality in almost 40% of cases. However, when it is isolated, these rates are reduced almost to half. But we also have to remember that in 30% of cases we will find associated anomalies that we were not able to identify at the moment of diagnosis, and that are identified in a postnatal stage. There is no differences regarding gestational age, size at the diagnosis or progression in utero. It is a severe ventriculomegaly, and this will give us the prognosis. But in isolated ventriculomegaly, the rate of severe neurodevelopment impairment will reach 50% and moderate neurodevelopment impairment in 40% of cases. The question is, can we perform a therapy before being born? We have to say that the repeated cephalocentesis and the ventricle amniotic shunt have had poor outcomes, with higher rates of neurological impairment when compared with neonatal treatment, and is not advisable treatment nowadays. Regarding the delivery, when comparing C-section with vaginal delivery, there were no differences. There is no indication of elective C-section in all cases, and the C-section will be protective in cases of macrocephalic fetuses, with a head circumference of more than 2 standard deviations, and there are no indications of ending the pregnancy earlier. But we have to have in mind that every case had its particularities, and it should be discussed always in a committee. Which will be the postnatal management? Ultrasounds will be performed to confirm the diagnosis and assess the associated anomalies that we weren't able or capable of detect antenatally, and also an MRI if necessary to confirm the diagnosis of associated anomalies. In these cases, we should always assess the follow-up with a pediatrician to evaluate the neurodevelopment of these children. Which are the surgical procedures in these children? Generally, it is indicated when there is an obstruction in the cerebrospinal fluid, and the indications are when there is a severe dilation or signs of intracranial hypertension. The surgeries can be ventriculoperitoneal shunt placement or endoscopic ventriculostomy, and the decisions are made with the neurosurgeons and taking into account the evolution of the newborn. A summary: when finding a ventriculomegaly, we will perform a study which will allow us to classify it as isolated or non-isolated. In the non-isolated cases, being of malformative or acquired form, the prognosis generally will be unfavorable and will be directly related to the etiology. So we have to try to diagnose the etiology to tell the parents the prognosis. And in the isolated cases, we have to remember the rate of false negative, more or less 10%. We will perform follow-up every 2 to 4 weeks. In case it is severe or progressive, we should tell the parents it has an unfavorable prognosis with neurological alterations in 70% of cases and perinatal mortality in 25% of cases. If it is a stable and moderate ventriculomegaly, we will tell the parents about the favorable prognosis in 70 to 80% of cases. And in case it is a mild and stable ventriculomegaly, we'll have a favorable prognosis in 90% of cases. In all these cases, a neonatal ultrasound will be advised, a neuropediatric follow-up, and finally, in severe and progressive cases with obstruction of the cerebrospinal fluid, the necessity of postnatal surgery should be discussed. And thank you.